very good day to you. The topic we are addressing our minds to is prevention of mother-to-child transmission in the context of human immunodeficiency virus, HIV, hepatitis B, and COVID-19 infections. I am Niyi Makinde from the Department of Obstetrics, Gynecology and Perinatology, College of Health Sciences of the Obafemi Awolowo University, Ile-Ife in Nigeria. To start with, we should know what emerging infections are. They are known diseases that are rapidly increasing in incidence or in geographic spread, such as HIV, human immunodeficiency virus, which has been with us since the past 39 years, Zika and SARS, of which COVID-19 is inclusive. We also have re-emerging diseases, which reappear after they have been on a significant decline due to breakdown in public health measures, or when new strains of known disease-causing organisms appear, such as tuberculosis, gonorrhea, and malaria. We also have endemic infections, which are persistent on a regular basis in a community. An example is hepatitis B virus. There are maternal and perinatal infections. Maternal and perinatal infections can be caused by so many organisms, microorganisms. One, viral, rubella, the causative agent of German measles, cytomegalovirus infection, varicella zoster infection, HIV, parvovirus, which we have in dogs as well, herpes, papilloma, hepatitis, Zika, and COVID-19, a form of SARS. Bacterial infections, examples are syphilis, gonorrhea, chlamydia, tuberculosis, group B streptococcus infection. Other agents, microorganisms that can cause maternal and perinatal infections are protozoan, example malaria, and toxoplasmosis. Fungal or mycotic infections, we have histoplasmosis, coccidioidomycosis, blastomycosis, and cryptococcosis. All right. And of course, because of these infections, there can be maternal disease. The mother can be affected by any of these diseases, and depending on the extent or severity, the quality of life of such a person is affected. And also, there could be maternal death. So some of these diseases, when they are severe, they can be life-altering, life-changing, or life-ending. And we can have fatal wastages, which, because of habitual abortion, and they can lead to intrauterine growth restriction, or stillbirth later, and can be the causes of congenital anomalies. And that's why we are talking about the prevention of mother-to-child transmission, PMTCT, of these infections I've mentioned earlier. What is PMTCT, prevention of mother-to-child transmission of infections? Simply put, they are a series of steps or interventions to maximize the health of pregnant women and ensure infection-free survival of their infants. You can see the key steps there. They are interventions to maximize the health of the pregnant women and ensure infection-free survival of their infants. And that's why we say PMTCT. That's the acronym. And of course, it is also called, if there is mother-to-child transmission of these infections, we call it vertical transmission. So it is the prevention of vertical transmission from mother to their fetuses and to their infants when they are born. First of all, we'll talk about PMTCT of HIV, prevention of mother-to-child transmission of human immunodeficiency virus infection. And the learning objectives are to gain competence in the following modalities of intervention. First of all, there must be HIV testing of all pregnant women. And this day, now we carry out provider-initiated testing and counseling, PITC, in that when the pregnant women come into the hospital, we do counseling and we urge them to have the HIV test. And the woman or the women, they have the option of opting out. But with counseling and recounseling, I've seen people who initially declined but later accepted to be tested. Because how do we know the enemies we have? Because these microorganisms, we cannot see them with the naked eye. And so we need to carry out extensive testing to know who harbors these microorganisms in their body so that we can intervene. So testing is very, very important. And of course, we should also do index testing. So if the pregnant woman is positive, we use the opportunity to invite her husband. And of course, in our antenatal clinics, we should promote couples HIV testing and counseling. But oftentimes, the men do not have the time to come. But we should, as healthcare givers, encourage the husband and wife, or the wife and her partner or her husband to come for testing. All right. Then number 2 objective is that we promote healthy living of the pregnant females with HIV. Of course, I should mention concerning HIV, there are 3 groups of people. People living with HIV, people affected by HIV, because if it leads to death, people can be orphaned, people can be widowed or widowed, so to say. So, and the people who live off HIV, healthcare workers or advocates, who go about talking about and intervening concerning HIV infections. So, we must provide provider-initiated testing and counseling. We counsel them concerning the necessity, and they now do the testing. And thankfully, this day and age, the tests we carry out are rapid, and you get them almost immediately, within a few minutes, when the woman comes to the healthcare facility. So, we promote healthy living of pregnant females with HIV. Number 3 objective is that we promote safer obstetric practices. What do I mean? Because of the risk of transmission from the mother to the fetus, even in pregnancy, things like amniocentesis, things like external cephalic version, we should not do them so that there will not be premature separation of bleeding between the circulation of the mother and the circulation of the fetus. Remember that in human pregnancy, we have the hemochorial type of pregnancy, and there's the maternal circulation and the fetal circulation are so close, just being separated by a few membranes, and that is it. So we advocate safer obstetric practices. And then when a woman is about delivery, we should prevent episiotomy as much as possible, because the woman might bleed, and before the baby is extricated totally from the mother, it might take some time, and the blood of the mother having HIV, having the human immunodeficiency virus, might be loaded in the blood of the mother, which can be transmitted, especially if there is abrasion of the skin of the infant. We should also not allow pregnant women positive for HIV to have prolonged labor. So we carry out safer obstetric practices. Number 4, and safer infant feeding. Now, what do? We carry out things, the baby has to feed the infant has to feed after being delivered. There are women who might have the wherewithal. They might be rich enough. They are on the high socioeconomic level. And so they might be able to feed their infant with formula feeds. But then some criteria needs to be satisfied before such is allowed. One, it must be acceptable to the woman. It must be feasible. It must be available. It must be sustainable. And it must be safe. But in the context of our own environment, in which poverty is, many more of our people are getting poorer and poorer by the day because of the downturn in the economy of the country, this might not be. And so, even in the context of HIV, we advocate exclusive breastfeeding for the mother who is even HIV positive. Why? Because of the endemic poverty. Many of these women cannot sustain giving their infants formula feeds so that the baby will not die from diarrheal diseases. Okay? And that's one of the things we look into. So safer infant feeding. So we sit down the woman and we talk it out with her so that she knows what to do. And of course, we discourage mixed feeding. That is, breast milk feeding and formula feed within the first 6 months of life. We discourage that. We call that mixed feeding because of the risk of the infant, developing HIV when there's mixed feeding. Number 5, there should be provision of prophylaxis and treatment for mother and child. There should be provision of prophylaxis of treatment for mother and child. Now, what do we mean by that? There are drugs, antiretroviral drugs that we give, and we have so many groups now that we can use. When we first started, it was zidovudine, AZT, that we were using. Before we knew it, there had been resistance to it, and that's why we discourage monotherapy. We now carry out HAART, HAART, which stands for Highly Active Antiretroviral Therapy, in which we give at least 3 drugs from at least 2 groups of antiretroviral drugs. And so we give these, and within a short time, the viral load, there will be viral suppression, and the viral load will decrease, the CD4 count will increase, and the woman leads a healthy life without opportunistic infections or the risk of the virus moving from the mother, being transmitted from the mother to the fetus. And when she's breastfeeding too, yes. So the mother has HAART, and the baby, the infant after being born, will also have antiretroviral therapy because he or she has been exposed. Now, there are high-risk babies. That is, infants born to mothers who are HIV positive, but such mothers have not had ARVs for at least 4 weeks before delivery of the infant, or mothers whose viral loads are very high, more than 1,000 copies per ml, okay? And so, such babies will need to be on treatment with 2 drugs, zidovudine and nevirapine. But those who are considered to be low risk will have only zidovudine for the first 6 weeks of life. And also, when the baby is being breastfed, okay, and it might be maybe extended, maybe to about two years, the first 2 years of life of the infant, yes, the baby should have the ARVs extended for at least some time after breastfeeding. So we just don't stop abruptly. We carry it for some weeks after breastfeeding. So that's what we are talking about, provision of prophylaxis and treatment for mother and child. Then, of course, we encourage the mother to adhere to care plan. Other drugs that she should take, called trimoxazole if necessary, intermittent preventive therapy for malaria, because we are in an endemic region for malaria. We encourage her, and other things that she needs to do, coming together to have health talk with the support group so that they can encourage one another. And number 7, reduction of stigma and discrimination. This is very important. Many people, they still run away from them. Many people They don't want to have any mixing with them, which is not right. Many people who are HIV positive, maybe they are sacked, or they are not given opportunity to have gainful employment once their status concerning HIV is known. Number 7, the approach to the managing HIV patients in pregnancy should be multidisciplinary. There should be integrated care. The obstetricians, the nurse midwife, all the health specialists, depending on how the woman presents, the pulmonologist, internist, hematologist, dermatovenerologist, yes, of course, neonatologist, and so on and so forth. Then we need people, the nutrition expert, and she should have psychosocial support. The social workers are included too. Family planning, we use that opportunity, yes, to talk to the woman, to counsel the woman concerning family planning and cervical screening, so that we can pick up before it becomes full-blown, or there is late-stage carcinoma of the cervix. We offer cervical screening so that we can pick up changes occurring in the cervix early on. Then treatment of opportunistic infections, and there must be focal support group. Mentor mothers are mothers who have gone successfully through PMTCT, and their babies, after they have had their infant early diagnosis, are found to be negative. So they are mentor mothers. They have gone through the disease treatment, and they know everything there is to know. And because they have gone through it, they'll be in a better position to explain to other mothers who have just been newly diagnosed and who are ARV naive patients, so to say. Then, of course, because we are in the endemic region for malaria, there should be intermittent preventive therapy for malaria with combination of pyrimethamine and sulfonamide. And number 9, documentation. Everything that is done should be documented, because when you don't document, it is as if one has not done anything. And of course, it's good when we document for monitoring and evaluation. And of course, we should aim at qualitative care, for these women when they have HIV, because our goal is to have HIV-free generations. So if we don't document, if we don't give qualitative care, how can we know how to improve? How can we bring about an HIV-free generation thereafter? Now, concerning the epidemiology of HIV, the national prevalence now is 1.5%. It used to be as high as 5.8 many years ago. I've said earlier that HIV has been with us now for 39 years. And the male to female ratio is 1.1 to 1.9. And the lowest prevalence is found in the northwest of Nigeria, which is 0.6%. And in South has the highest prevalence of 3.1%. Osun State has a prevalence of 0.9%, less than 1% now. And at OHCAC, a 2018 survey, the prevalence among antenatal clinic attendees was 0.6%. And infected infants, well, we had 25 to 40 out of 100 of them. So that's the epidemiology concerning HIV. Okay? And now, since we are talking about PMTCT, prevention of mother-to-child transmission of HIV, there are 4 elements to these. Number 1, the first prong, so to say, is primary prevention in women of reproductive age group and partners. What do we mean by that? Women from about 15 years of age, they can get pregnant, and by 49. But this day and age, because of medically assisted reproduction, IVF and what have you, many women now deliver in their 50s and in their 60s. They deliver very late because of infertility. Now, well, we might need to review that. So, but the reproductive age, generally speaking, is from 15 to 49. So there must be primary prevention in women of reproductive age group and their partners, in that their lifestyle, the ABCD of prevention, okay? Abstinence, if you don't have a partner yet, you are not yet married. Then mutual fidelity within the couple, okay? Persistent condom usage, correct persistent condom usage, and so on and so forth. And prevention of being infected in the healthcare facility. Needle pricks, unnecessary needle pricks. So there are ways of handle all the things that we need or use within the healthcare facility. While you are operating, you are careful, you are gloved, because we have women who are doctors, we have women who are nurses, we have women who carry out one chore or the other within the healthcare facility, and they need to have go through universal precautionary measures. All right. The second prong is we have prevention of unintended pregnancy among HIV positive women. Prevention of unintended pregnancy. Well, pregnancy can be unintended, can be unwanted, it cannot be planned for, but we encourage women to plan for their pregnancy because it behoves them well. The chance of dying from a pregnancy, from some studies done, they see that many more women die from pregnancy than from road traffic accidents. Yes. And the problem in pregnancy can be the problem of TOO, too early, too late, too many children born too frequently, decreasing the spacing between one child and the other. So we encourage women not to have unintended pregnancy, because when the pregnancy is unintended, they will not take care of themselves properly and the pregnancy. And so the baby is likely to come down with HIV infection later. So the second prong is that there should be prevention of unintended pregnancy among HIV positive women. They have been tested and they are known to be HIV positive, but they should be encouraged not to have unintended pregnancy. Number 3 prong, prevention of HIV transmission from women infected to their infants. The woman is positive, she's now pregnant, or before she's pregnant, her status has been known before she's pregnant, and so she plans her pregnancy. And from the beginning, we encourage her to confirm the pregnancy, to know the location of the pregnancy, and we start the care of such a woman early enough in pregnancy so as to prevent HIV transmission from the mother to the infant. So, and all the things I mentioned earlier, that there are modified obstetric practices in HIV positive women. As much as possible, we prevent amniocentesis. As much as possible, we prevent external cephalic version. We want to change a fetus who is in breech position to cephalic position, and you carry out external cephalic version. Okay, some of these chorionic villus biopsies and what have you, we should not carry out such so as not to transfer, because of the risk of transfer of infection from the mother to the fetus. The fourth prong is provision of treatment and care and support to infected women, their infants, and their families. Yes, all the ARVs, one or two people that the woman trusts, somebody close to her, if she's not so close to her husband, we encourage couples coming together, that there will not be any secret at all that they keep from one another. So the treatment, because she might forget to take her drugs. And concerning care plan, we encourage at least 95% of the time, the woman should be taking her drugs so that there will not be any resistance, so that there will not be any transfer from the mother to the fetus. So, and care and support, eating well, taking all the things, vitamin supplements, taking things like sulfonamide combined with pyrimethamine to prevent malaria, and psychological support. Because many women, thank God this day and age, many women, they suffer psychologically. Immediately they know that they are HIV positive. Many of them, they were not promiscuous. Many of them, it was through their partner, their husbands, their partners, who maybe went out or who is polygamous. Okay? And that's it. They are infected. All right. And some of the women were raped. So the virus was passed on. All right. Yes, I mentioned earlier HTC, HIV testing and counseling. We prefer that the couple, the man and the woman, they come together to the clinic. But we should encourage this the more. Many of the husbands or partners of these women, they do not have the time, probably because of the setup of most antenatal clinics. Women spend hours on end waiting to be attended to. But we encourage couples testing, both of them coming together. And I said earlier, we provide provider-initiated testing and counseling, PITC. And there are 5 C's concerning testing and counseling. 1, there must be consent. There must be confidentiality. There must be counseling. Counseling is much more than giving information. Counseling is much more than talking for a few minutes. It is confidential dialoguing. You give information to the woman, you receive a response from her, and so you will see. So counseling is much more than giving information. It is confidential dialoguing between the counselor and the counselee. And it must be correct, high quality, okay? And there should be connection. Peradventure, link it to prevention and treatment. Family planning. A woman who is gravid at 7, a multi-para, comes to you. You offer her family planning counseling and whatever you can do. And because she's multi-para or probably has had many sexual partners, you want to screen her for CIN, cervical intraepithelial neoplasia. And so you use that opportunity of her bringing her coming for care during pregnancy to test, to screen her for CIN, and to offer her family planning counseling and intervention. Okay? So, HIV testing and counseling, very, very important. And like I said earlier, how do you know your enemy that you cannot see with naked eye? So we need to counsel and to test. And may I say, there's still the option of opting out. We don't force a woman, but you appeal to her. And over the years now, like I said, HIV has been with us for 39 years now. People now accept HIV testing as if they are doing their PCV, packed cell volume. Yes. There is no more shame. Yes. We are discreet when we have them, but there's no more shame. And some even say it openly. They are not ashamed anymore, unlike before. The stigma and the discrimination are decreasing, but then we can still do better. And again, we are talking about PMTCT, prevention of mother-to-child transmission of HIV. We should talk about ARV, antiretroviral prophylaxis and treatment. And I mentioned earlier that we carry out highly active antiretroviral therapy. Now, what do we mean by that? We have at least 3 drugs being administered to the woman, and these drugs are from at least 2 groups of the antiretroviral drugs. We have the nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, protease inhibitors, okay, integrase inhibitors, etc., etc. All right. So we combine these. All the drugs that we use should not come from only one group, from at least 2 different groups, so as to prevent resistance. And may I say now that we carry out TLD, the drugs we use, antiretroviral drugs that we use for heart, tenofovir, lamivudine, and dolutegravir. Tenofovir, lamivudine, and dolutegravir. They are from different, nucleoside, reverse transcriptase inhibitors, and integrase inhibitors. DTG, dolutegravir, is a new that we started a few years ago. All the concerns about possible teratogenicity have been allayed. We now use it safely. The suppression, the viral load suppression is very, very good, and we've been having good results about it. Now, the next thing we move to is safer delivery practices. We must avoid any invasive procedure, like I've mentioned earlier, like amniocentesis, any invasive procedure during pregnancy because of the risk of transfer from the mother to the fetus. Remember, the placenta, the human placenta is hemochoria. The thin membranes separate the maternal circulation from the fetal circulation. So avoidance of invasive procedures. And also, while being delivered, we avoid episiotomy, that is cutting the perineum, the outlet of the birth canal, to effect an easy passage of the fetus while the baby is being expelled from the birth canal. And we should avoid laceration as well. Then we avoid instrumental delivery because of the risk of abrasion, injuries to the baby and the mother, and the woman will bleed, and the infection can be passed from her onto her baby being born or just being delivered. And of course, we avoid as much as possible prolonged labor, because the longer the fetus stays within the birth canal, the greater the probability of such a baby being infected. And of course, when there's rupture of membranes, we prevent as much as possible prolonged rupture of membranes. When the membranes have been ruptured for over 4 hours, there is a greater risk of the mother infecting her baby. We also have counsel on infant feeding, okay, for safer infant feeding. That's what we carry out. And what we prefer in our setting is exclusive breastfeeding, even for HIV positive women. And that's why we encourage the women to start their ARVs as early as possible in pregnancy. And they should take the correct dose. And thank God, we don't have pill burden now. One of the reasons women did not take to care plan, adhere to care plan many years ago, was because of the pill burden. There was a time a woman will need to take about 8, 9, 10, 12 drugs, pills per day. That was a burden, but this day and age, we have co-formulation. So she might just need to take it maybe once a day, apart from the vitamin supplements and what have you. So things are better now. So some of the drugs will be 3 in 1, like what we have now, that we give our women. So the pill burden is no longer there. So if a woman has not had her ARVs for at least 4 weeks, if she delivers, such a baby exposed to her will be termed high risk, because the mother has not had ARVs for at least more than 4 weeks before the infant is delivered. So the baby from such a woman is high risk. And of course, if the woman has had it for many months, and the viral load is less than 1,000 copies per ml, yes, she's low risk. Okay? And exclusive formula feed is also allowed, but I've said the AFAS criteria must be followed. If the AFAS criteria are not satisfied, it is advisable not to allow the woman to have exclusive formula feed. Apart from the cost, yes, we are living in an area with endemic poverty, and many more Nigerians now are now living in poverty. Now, the first criteria has to do with acceptability, feasibility, availability, sustainability, and safety. Yes, if those 5 criteria are satisfied, then the woman can have exclusive formula feeds. And of course, when we give and we avoid mixed feeding as well, I should mention that before I leave that. Mixed feeding is having the infant to have breast milk and formula feeds or other complementary feed before the 6th month of life. So that's what we call mixed feeding. Well, I should mention the goals of ARV therapy, antiretroviral therapy. Number 1, clinical goals: to have prolongation of life and improvement of quality of life for the mother. Time was when we were not giving, when we never had ARVs to give. The mother could develop opportunistic infections from head to toe. And of course, when such women, the WHO classification, you will see them, what they bring, lymphadenopathy. Some of them, they will have lost over 10% of their weight, body weight, and they will look cachectic, diarrheal diseases, oral thrush, vaginal thrush, skin infections, etc., etc. So when we start the clinical goal, the ARV will prolong the life of the woman, and also there's improvement in the quality of life that she lives. The second goal in giving ARVs is virologic, the virologic goals. It gives we aim at the greatest possible reduction in viral load, less than 50 copies per ml, for as long as possible to prevent disease progression and prevent or delay progression. That's virologic goal. The third one is immunologic goal, immunological goals. That is to allow for immune reconstitution. Remember, in HIV, the woman's immune system is dampened, is reduced. Okay? Remember that pregnancy on its own, there is diminished immunity, both humoral and cellular. So, we want a quantitative immunologic goal, the CD4 count, to be in normal range. And the qualitative, there must be a pathogen-specific immune response. So those are the immunological goals that we aim at. Okay, quantitative as well as qualitative. The next goal is therapeutic. There must be rational sequencing of drugs to achieve previous goals and limit drug toxicity. Hello? Many of these drugs are very toxic. I remember nevirapine, when we were still using nevirapine. It could cause Stevens-Johnson syndrome, and it could be lethal if not properly treated, because the woman will develop sores from her mouth right to her anus, and she might not be able to feed, and she could die. And of course, we had many initially, all the complications, side effects there are, could kill. All right? We could have liver side effects, affecting the kidneys, affecting so many from head to toe, and that is it. So there must be rational sequencing of drugs and we must limit drug toxicity, and that's why a combination. And remember, we are using combination of drugs. Okay? We must not use one drug that will potentiate the effect of the other. Then when we are treating comorbidities, because TB and HIV coexist in the same woman, we must be careful. Some of the drugs, there can be drug-to-drug interaction, like rifampicin and whatever, and the woman on HIV. There are special considerations that we need to take care of when such a woman presents with comorbidity of HIV and tuberculosis in pregnancy. And we facilitate adherence. That's still part of the therapeutic goal. That is the care plan that we give to the woman, how she should take her drugs, when she should report at the facility, she should eat well, the focal support so that they can give her psychological support. Yes, we follow this. The reason being this, when a woman is on ARV, we want her to take the drugs as 100%, as much as possible. But if she must miss it, she must not, the adherence must not be less than 95%. That is, let's say in a month, she ought to have taken her drugs 30 days, 30 times, once every day. Maybe she just misses it once. And if she misses it, she lets us know. And that's why when they come to the clinic, to the healthcare facility, we ask them about their drugs, how they are taking it. And we look at the supply. And we should not allow the drugs to finish before they come for a refill. So we've been doing this and we've been getting good results. So the therapeutic goal is, one of the things we want to achieve is to facilitate adherence to care plan, not just to ARV alone. Then epidemiological, the last goal of ARV therapy is to reduce HIV transmission. Then the guidelines for PMTCT 2018, there must be initiation of lifelong ARV treatment for all women who are pregnant. Lifelong. Once you start the ARVs, it's lifelong. Okay? Who are pregnant, who are breastfeeding, or who have an infant less than 1 year, regardless of CD4 count. So that's the guideline. Those are the guidelines we are following. Immediate initiation. You test, positive, you treat. Okay. Then, there must be repeat HIV testing for HIV negative women after 3 months during pregnancy. What do I mean? The woman comes at the 4th month of of pregnancy, at a gestational age of 4 months, she's tested, she's negative. It behoves the health caregivers to test her 3 months after or before she delivers, just to be sure that she has not become positive. Why? Because when she was first tested earlier, she could have been in the window period. And that's why it is necessary to have a retesting 3 months after the first one, okay, and before breastfeeding or in labor. And yes, so repeat HIV testing for HIV negative women who have initially tested negative, okay? And also, when they come for their child's 6-week immunization, you seize the opportunity. You can test again to see that the woman has not converted. Amen? All right. Now, we should talk about early infant diagnosis, EID. Because what is the essence of prevention of mother-to-child transmission? We want to prevent transmission from the mother to the fetus so as to have HIV-free generations, HIV-negative generations. That's the essence. And so, the baby or infants are the products of the pregnancy. So you want to see the products of what we have been doing to the woman. And so we carry out early infant diagnosis. And we use dried blood spot paper at the 6th week of life. After the baby has been born, 6 weeks, we test the baby. We have special papers that have been provided for it, and we feel accordingly. There are specific things to do concerning these. Like I said earlier, a high-risk infant is one born to a mother with high viral load, greater than 1,000 copies per ml. And such an infant will be placed from birth on nevirapine and zidovudine twice daily for 6 weeks. And the mother, and also a baby, an infant born to a mother who have been on ARV for less than 4 weeks. Such an infant will be a high-risk infant. A low-risk infant will be placed on zidovudine once daily for 6 weeks. So that's the difference between handling, Then we should talk about elimination of mother-to-child transmission of HIV and syphilis. There are some other diseases. There are comorbidities. I say they are infections of evil synergy. HIV, syphilis, HIV, tuberculosis. Okay? They are partners in crime, so to say. Okay? If you have one can lead to the other coming on and being more fulminant than usual. So now we are talking about elimination of mother-to-child transmission of HIV syphilis. Because syphilis, there can be a sore, and it can be the entrance the portal point of entry, okay, when such a person engages in unsafe sexual intercourse. Yes, because of syphilis, there will be ulcers, so it can be passed on. HIV can be passed on too. So, these are of global public health priority. The process, the progress, and the program integration. Because what is our goal? We want to breed HIV-free generations. All right? So we go through a process, the progress, we monitor the progress, and program integration to cover all these other diseases that I've talked about. Number one, we talk about the impact criteria that we have been doing. All we are advocating to do, we want to aim at less than 50 new pediatric infections per 100,000 live births, and that the transmission rate should be less than 5% in breastfeeding populations and less than 2% in non-breastfeeding populations. Remember, a woman can opt for we advocate exclusive breastfeeding in our own setup. But then, if a woman has opted for exclusive formula feed, after the AFAS criteria have been satisfied, yes, the percentage, the transmission rate in such a population is usually about less than 2% where it is properly done. Then, less than 50% of cases of congenital syphilis, because if there is syphilis in the mother, it can be passed on even to the fetus, to the new infant. So there can be congenital syphilis. So we want to aim at a goal of less than 50 cases of congenital syphilis in 100,000 live births. All right. Process criteria now. Okay. We want that at least we encourage all women to come to the hospital. So, at least 95% of them, of the women in the community, we encourage them to come for antenatal clinic attendance so that they can be taken care of. At least 95% in a community. We encourage that as much as possible. Okay? Even if it is only once, or usually we don't practice focused antenatal care, but at least get them to a facility. And even the contact that you have with them, you maximize it. And we might need to follow up. Then, talking still about the process criteria, 95% of pregnant women to receive HIV plus syphilis testing. All those who come, at least 95% of them should receive HIV and syphilis testing. And also, 95% to receive treatment. So we advocate that. So that's about the process criteria. Remember, our goal is we want to breed HIV-free generations. And that's it. Okay, how? So, human rights concern, having all these tests, the process, the progress, etc., is of human rights concern. Health is a human right concern. So it behoves the government, it behoves the healthcare givers to do something to effect this and make the government, wherever in the community, to take up this responsibility. Health is a human right concern for each and everyone. And also a woman who is pregnant, who is about to deliver. Yes. So human rights concern, it should be noted. So it is the inalienable right of every woman to have all these things done for her. But alas, it is not yet so. Then we should know that there should be gender equality. Gender equality. But, the women are now, anything that should be done to encourage that women are better treated in pregnancy and outside of pregnancy should be advocated. It is their right to have good health care. And of course, look at the maternal mortality that we should still have. It is a human right concern. And some people can still die from HIV if not well treated. So that should not be allowed. Okay? And of course, there should be community engagement. If we engage the community, the opinion leaders in such a community will encourage these pregnant women to come. And they can come to see what is being done. So it's not as if the women are being taught something. Even if we talk about family planning, when they know that it is for the benefit of the women and their children, and even the fathers in the community, the opinion leaders in the community, yes, it will help to propagate all the things that should be done so that we breed HIV-free generations. Okay, process. Antenatal coverage has at least one visit, greater than 95% should have this. HIV syphilis testing, greater than 90%. You can see everything aims at least 95%. That is what we are aiming at. Then ARV testing, at least 95% in that community should be tested. Treatment of syphilis seropositive pregnant women, at least 95%. You can see everything at least 95%, 95%. Conclusion. The triple commitments by WHO, World Health Organization, that elimination of mother-to-child transmission of HIV, of syphilis, and hepatitis is possible. Okay? It's possible. So, it's possible. And we have target dates. Then, of course, in conclusion, concerning HIV infection, if smallpox has been eradicated, bubonic plague that was in the 14th century, if I recollect rightly, has been vanquished. Is there hope for HIV? Yes, I think there is hope. The verdict is, I think there is hope. Because if there is life, there is hope. And since in my experience, in our own setup at Ile-Ife, the prevalence rate used to be 5.4%. That is, 54 pregnant women were positive for HIV many years ago, over 20, 25 years ago, out of 1,000 cases. But now, we now have 6 pregnant women being positive out of 1,000 cases. There is hope. From 54 has been reduced to 6. Maybe in 10 years' time, before 2030. Yes. Which is a target date. Well, maybe HIV would have been vanquished, and we'll breed HIV-free generations. Thank you.